So to begin, I do not have any relevant financial disclosures. As I alluded to, the outline of my talk today will be reviewing the current state of maternal health and most importantly, how the impact social determinants of health have on that. We also want to understand the challenges and the management and the risk for future cardiovascular events in pregnant women and learn how to best adapt, again, strategies and promote solutions to improve outcomes regarding this crisis that we're seeing that's specifically disproportionately affecting Black women. Now, when you think about the United States as a whole, given the remarkable advancements we've made across nearly every aspect of healthcare in the last quarter century, it's shocking that women in the US are still more likely to suffer a pregnancy-related death today than even back in the 1990s. And this graph here very nicely demonstrates how we actually are compared to those countries or nations that we're comparable to. And as you can see, unfortunately, we have the highest amount of maternal deaths as us in the United States. And when you actually delve deep into what's the most common cause of where we're seeing this mortality, it's actually cardiovascular disease. It's leading the way. In about a third of pregnancy-related deaths are from cardiovascular disease, peripartum cardiomyopathy at the very top. However, very soon thereafter are hypertensive disorders of pregnancy, stroke, as well as others. This translates into 1 in 3 deaths, despite the United States nearly providing 2.5 times more per person on health than any other developed country where mortality rates continue to rise for us, but decline for them. And when you think about maternal mortality, it's just the tip of the iceberg, because for every maternal death, there are 75 to 100 more women who actually suffer life-threatening complications during pregnancy or childbirth. Disparities exist, as I alluded to, and we know that there are higher mortality and morbidity rates among non-white as well as low-income women, with Black and American Indian women 2 to 3 times more likely to die during pregnancy as well as the postpartum period. And when we think about the top 4 risk factors for this maternal mortality, we know advanced age. As it stands right now, women are having children later on in life, and as a result, they may be more prone to more chronic medical conditions, including obesity, hypertension as an example, which are other risk factors why we're seeing maternal mortality. But we also know that a risk factor is race. And when we think about that, 52% of Black women have at least one risk factor, those risk factors traditionally that I mentioned, like elevated blood pressure, cholesterol, diabetes, etc. And 20% have 2 or more of those risk factors. So it should come as no shock that nearly 60% of Black women above the age of 20 have some form of cardiovascular disease. But the issue when we think about race is that we as a society over-rely on the biology and the genetics of race, and we undervalue the actual issue, which is the social construct of race. The fact is that these social determinants are playing a role with systemic racism at the core of why we're seeing Black maternal health and this epidemic. And I want to highlight this really by walking you through this graph where systemic racism, starting at a structural and institutional level, will lead to interpersonal racism. That could be just bigotry that's explicit or even the implicit biases that many of us may experience ourselves. That leads to higher amounts of poor outcomes, such as these social determinants of health, right? Structural conditions in which people are born, grow, live, learn, work, play, pray, and age that influence their health risk and outcomes. As I said earlier on, it's that makes 80% of our health outcomes. It is that, the social determinants of health. That leads to the healthcare inequities that we're seeing, the differences in the availability, access, which we'll be talking about later on, and quality of healthcare services. That also leads to health inequities from differences in the burden of many of these illnesses, injury, disability, and mortality between these groups. And all of this reflects negatively. It impacts women of color much more severely than their counterparts. We also know that when we think about systemic racism and interpersonal racism, it can absolutely affect the physiology or the physiological effects. Toxic stress, increased allostatic load, something called Superwoman schema. And this has been very nicely studied where history of stereotyping and oppression, history of disappointment, and mistreatment and all of the above can lead to a higher amount of allostatic load. It could affect our sympathetic nervous system, our inflammation, our hypothalamic pituitary axis, all of which makes these women more vulnerable prematurely for cognitive as well as cardiovascular health. So again, social aspects are really leading the way. And the fact is we need to change this, because when it comes to pregnancy-related deaths, they are preventable. 3 out of every 5 pregnancy-related deaths are preventable. So 60% of the time they are preventable. So we have to do better. And that's really where the question is, how can we do better? And as I mentioned, I was so fortunate to lead a paper that was published in Circulation Cardiovascular Quality and Outcomes based on the Association of Black Cardiologists back of February of 2021, where we didn't want to only highlight these issues, but we wanted to talk, as I mentioned, about the solutions. So what are these solutions? Well, we know that in many of these vulnerable populations, they have an exuberant amount of trust for their community leaders that have an opportunity to really provide them the soundboard of information, such as the faith-based community, churches as an example. We also know that there could be a lot of trust through beauty parlors and barber shops. We've seen a series of research studies that have actually utilized these community leaders to actually improve access, but also quality of how we're managing a lot of these chronic medical conditions. And I bring up trust because it is very well known that populations such as the Black community may have higher amount of mistrust due to, again, that systemic racism and all of the wrongs that they have had to experience. So working with our trusted community collaboration is key. We also know that we want to also work with a trusted perinatal collaboration. So as clinicians, specifically physicians, we can collaborate, and we must collaborate with our nursing staff, who are absolutely going to allow for us to think about the patient in the center, right? All of us working together and collaborating, including our midwives and doulas who are trained companions who support someone through a significant health-related experience. They're not clinicians, however, they are so impactful in that care team. And we know that when it comes to the Black maternal health crisis, doulas really help to mitigate the amount of what we're seeing right now in terms of the disparities for mortality as well as morbidity. We wanted to also address the fact that cardiovascular disease is something we could prevent 80% of the time, and that's through a lot of traditional risk factors, which we should be able to modify. So how about we start prevention and focusing on even primordial prevention, meaning prenatal care? How about we incorporate our pediatricians into the discussion, understanding that if we teach our children how to live healthy lives, hopefully we could prevent in the future from them having any of these chronic medical conditions as an approach as well. We need to diversify the workforce, so deploy a healthcare workforce that displays diversity of backgrounds and experiences. Data shows that patients that are able to have a synergistic background, if we think about it, with their provider or their clinician tend to have better outcomes. They tend to have better outcomes because they understand from a cultural perspective, but we also know that when we have a more diverse workforce, that leads to better outcomes as well. We need to revamp curriculum, medical school as an example, right? We have to modify structural racism and provide implicit bias training, and also make sure that we bring cardio-obstetrics to the forefront of cardiology as well as OB, primary, family medicine, all of the curriculum that are out there. And as we heard earlier, research is just so despairing in terms of the percentage of women that are actually enrolled in these research studies. So we need to expand research and registry data and think about a maternal heart team. How can we remodel healthcare delivery and care coordination? And the importance of a maternal heart team is the fact that when you are pregnant, there's so many cardiovascular changes that we see. There's an increase in intravascular volume, cardiac output, heart rate, systemic vascular resistance goes down, the stroke volume increases, our blood pressures vary depending on the trimester, and we also know that venous pressure increases, and as a result, many of these women may not present with cardiovascular disease until they're pregnant. Valvular dysfunction, as an example, a lot of times starts to actually bring to the forth of us during that pregnancy. And that's where a maternal heart team is key. So who's key on that team? Typically a obstetrician, possibly a maternal fetal medicine physician. Cardiology, absolutely, but we also want to make sure primary care providers are included in that as well. The nursing staff, midwives, all of those key collaborators to improve the quality of care that we're seeing. And the intention of this is not just to diagnose those heart conditions that maybe they were congenitally born with or acquired during their lifetime but did not identify until they were pregnant, but we also want to acknowledge these adverse pregnancy outcomes that occur during pregnancy. Hypertensive disorders of pregnancy, gestational diabetes, preterm delivery, small for gestational age miscarriages. All of these are risk factors in the future for these women to have cardiovascular disease. So identifying them and making sure that they have flowing, exceptional follow-up and care, be it with a primary doctor or a cardiologist, is so pivotal to the cause. I'm fortunate that my health system acknowledges that cardio-obstetrics is an important thing that we have to really make improvements for. As a result, we created a maternal heart council that really wanted to go beyond just that maternal heart approach, where we think about women across their care continuum, starting with preconception, thinking about acute care when they're in the hospital, thinking about that antepartum ambulatory care, and lastly, focusing on that postpartum care. And really the mission of this was to ensure that disparities in care are mitigated, and most importantly, especially during that first year postpartum, which is so critical. And why is that? It's so critical because 1 in 3 mortalities are actually occurring 1 week to 1 year after delivery. This is an example from the California Department of Public Health, where they've created algorithms to make it easier for us as clinicians to identify which patients may be at the highest risk of having adverse pregnancy outcomes, and who may benefit from having that collaborative team approach, not just the obstetrician, maybe including the MFM, and definitely including the cardiologist. And I think it's important to ask the question, when we're seeing women as well, when was your last pregnancy? Because as I highlighted, up to 1 year after the delivery, that's when you could still see these ongoing issues related to their pregnancy, and more importantly, it could be due to cardiovascular disease. So when we think about it, research indicates that there's a higher lifetime likelihood of cardiovascular disease when women experience complications during pregnancy or postpartum. These could include, as I mentioned, the hypertensive disorders of pregnancy, gestational diabetes, HELP included in that, preterm birth, and small for gestational age infants. And when we actually think about preeclampsia, and I bring that up because it is a very common cause of future transitions into high blood pressure, in the sense that women that have preeclampsia are 4 times more likely to eventually experience hypertension. They're also 8 to 10 times higher risk of having early onset. Specifically, it will be 8 to 10 times higher of having hypertension if they had early onset preeclampsia, which is prior to 34 weeks. But more notably, preeclampsia can lead to a 2-time higher risk of stroke, cardiac ischemia, or venous thromboembolism, and that could be up to 20 years after their pregnancy. And this is why it's important that these women are followed for their lifetime. Primary care, 100% important, but thinking about that cardiology involvement as well is key. So how do we think about this? Well, we know that we need to screen for these conditions, think about the signs and symptoms to look out for. I include mental health screening because that's another pivotal part. As I said, Superwoman schema, the stress, the allostatic load that mental health can take a toll on really is what led ACOG to at least say we need to have an ongoing 12-week follow-up period, something called the 4th trimester, where we screen for mental health. We also talk about contraception because that's important, especially if they have any of these adverse pregnancy outcomes. We also, more importantly, talk about future pregnancies, and lastly, ensure that we refer them over the next 3 to 6 months to a primary care physician or cardiologist to pass that torch over to make sure that they don't have any interrupted care. And as it stands right now, we know that from a legislative perspective, there are a lot of things that we are doing. We're making, I think, a lot of leeway when it comes to even the Build Back Better Act. I'm so fortunate to see that a lot of that, including the Black Maternal Health Momnibus, which is specifically targeting Black women and the care of Black women during their pregnancy, are trying to promote a payment model that actually incentivizes high-quality care and non-clinical perinatal services. The only way to do that is to grow the perinatal workforce and ensure, as I mentioned, that we diversify it. We need to support mental health services, as I mentioned. And because of the fact that these issues are occurring up to 1 year postpartum, we need to expand insurance. The fact is Medicaid, 50% of pregnancies are covered by Medicaid. And in the vast majority of states, they stop coverage 60 days after the delivery. A lot of states need to think about mandating that, and that's where a lot of these initiatives are coming from a legislative perspective. And that's something the Association of Black Cardiologists are working on with these legislators as well. We also want to trust resources in digital platforms to identify barriers to coverage of remote physiological devices such as ambulatory blood pressure cuffs, which Dr. Bello will be talking about the importance of later on in her talk, but also glucose monitoring to make sure that we can acknowledge to these women that they may have these conditions, but that they have easy access to actually check them when they're home. Thinking about telehealth, we talked about telehealth in the first session, but we know that it provides flexibility, but there are some limitations when it comes to the vulnerable patient populations. I would say that it's difficult to provide a compassionate patient-provider relationship over the computer. So as a first visit, telehealth may not be the best, but it's definitely an option to allow for more flexibility. We also want to improve health and make sure that the surveillance systems are also up to par. And lastly, we really want to think about spotlighting influential stories. One thing about the Black maternal morbidity and mortality crisis is that income and education does not protect these women. Irrespective of their education and their income, the mere fact that they're Black women living in America, they are more likely to die during their pregnancy and up to 1 year postpartum than their white female counterparts. And that's where professional society collaborations, I think, are key. The American College of Obstetrics and Gynecology, the American Heart Association, the ACC, the ABC, we have to think about guidelines that are specific to these women and are very much so patient-focused. And I think one thing that we could acknowledge, and what we've heard even from our first session, is that sometimes people's voices and our patients' voices and stories are not being listened to. And that is a big key as why we're seeing these disparities as well. So a key step to improving Black maternal health is acknowledging Black mothers' concerns. That's an easy step, but it's a key step. And in summary, maternal health is experiencing an ongoing crisis in the United States that is disproportionately affecting women of color, especially Black women. Having collaborative teams in place ranging from cardio-obstetrics with the inclusion of pediatricians, along with doulas, midwives, and trusted community members may help to mitigate this. Understanding the role that these social determinants of health play, especially when focusing on access to quality health care, is important. But beyond that, we have to improve health literacy, focus on the importance of preconception counseling in the critical first year postpartum, and create a trusting patient-clinician relationship that acknowledges women's concerns. The goal for all of this is that we want to ensure that we're executing solutions, again, solutions that are unique to your country, your state, your city, your county, but more importantly, the individual health system as well as the patient. So with that, thank you so much for at least allowing me to give you some insight on all the work that we're doing on the Black maternal health crisis.